Started your 2 minutes time. Amruta, are you taking it?
Yeah.
Are you ready?
Yes, yes, ma'am.
There is another page also.
Yeah. Yes, ma'am. Next page.
Started your 10 minutes time.
Hello, I'm Amrita, one of the exam candidates. I have read the instructions and I'm ready for the structured discussion.
Okay. So after looking at the scenario, what will be your initial line of management?
After, I would like to introduce myself with the patient and as a post-operative doctor, a post-operative ward doctor, and I will confirm her name and age. Then I would like to ask her about the symptoms which she is having regarding pain, and is there any, if there is any dizziness, or how is her fluid intake, whether she is able to tolerate or not, and any bowel or bladder symptoms, whether she is able to mobilize properly. And then I will quickly examine her general vitals, recheck, abdominal examination for any distension and wound site, surgery site, any tenderness also, and vaginal examination if there is any bleeding from below, as she has underwent a surgery, laparoscopic hysterectomy. Then simultaneously, I would like to see if to resuscitate the patient by keeping an IV access and take bloods for blood grouping and cross matching, and also for full blood count, urea and electrolytes. Patient will be given IV fluids, and I would like to inform her in a empathetic manner that she has some concerns, and it may require another operation. And I would also apologize her for the mishap. I would like to inform I would like to call upon my consultant as well and inform after informing the patient and after taking the consent from her for explorative laparotomy, I'll inform the consultant, OT, and anesthetic anesthetist, and also the OT staff.
Okay.
This will
What
be
are yeah, what are the possible differential diagnoses will coming to your mind after seeing her?
first of all, as it is post-operative period, I'll check whether she is having a sufficient pain relief or not, and also looking at her vitals, which showed that there is a increase in pulse rate and uh, blood pressure was falling. So most likely there can be internal hemorrhage and also other causes like ureteric injury and infection, and also any dehydration should be checked.
What? I didn't get you. Please repeat it.
Uh, as it is a post-operative period, first of all, I would like to see whether she is getting sufficient pain relief,
Mm-hmm.
and looking at her vital uh, status, which was given to me, her pulse rate was increased,
Mm-hmm.
and also there is decrease in the blood pressure. So mostly there can be that can be due to internal hemorrhage, uh, and other causes can be like we have to rule out any ureteric injury or any other injury
Mm-hmm.
um, during the surgery, and whether the patient is well hydrated, and I have to look for her hydration, and also there can be infection chance.
Okay. Okay. Now, what will be your further management if you will diagnose hemoperitoneum on ultrasonography?
Yeah. Yeah, after explaining the patient, and she will be taken to the theater. I'll also have to tell her that her discharge will be delayed, and so after the consent, um, exploratory laparotomy will be done along with the consultant, and WHO checklist will be followed, and also after resuscitation by IV fluids till the blood arrives. After opening the abdomen, one should look for any bleeding points and secure hemorrhage. If essential, help from other specialties need to be taken. And also during this, as she mostly can have the hemorrhage risk, so blood bank should be informed, and also she should be provided during the surgery. Should her vitals need to be maintained, and once the surgery during the surgery she can be provided with antibiotics as well, and her risk for venous thromboembolism should be assessed. Thromboprophylaxis after the surgery should be provided. She will be shifted to HDU for continuous monitoring for the post-operative period until she is stabilized by input-output chart, analytics, and antibiotics, along with the thromboprophylaxis. Once she is
Okay.
stable, she can be shifted to the ward, post-operative ward.
What are the clinical
And
governance issues in this case?
once as soon as possible, when the patient is stable, she should be debriefed about the uh, procedure and what are the uh, measures that have been taken, and she should be conveyed all the problems like as a duty of candor should be done, and the incident form should be filled up, and also the patient should be informed that risk assessment team of experts will be conducting detailed. investigation, so that whenever the report is available, she will be informed um, with the transparency. And after the recovery, she will be discharged with the um, after complete documentation. She will be given a letter to the GP as well, right back to the GP, as she needs to be followed up with the GP.
Okay. Anything else you wanted to add to any of these questions?
And she will be told about given any red flag signs, like any further complaints with the post-operative period. She will be given 24 hours contact number to the hospital. That's all.
Okay. Thank you. Thank you, dear.
Thank you. Thank you.
Yeah. Last 1 minute remaining, but okay. Overall, a good attempt, what I will say. Anybody would like to comment upon her performance? Otherwise, we will go ahead with the answer key. You would like to comment about your performance, Dr. Amrutha? No. You want to be quiet.
Maybe some history I missed.
Okay. See, this is a
About the
post-operative
previous,
patient.
yeah, operation notes, I forgot, ma'am. I
Yeah,
should take
post-operative
her.
patient. So you have to just take details of that point only. Details of those points only. You do not need to go in so much of details. Indication of the
Okay,
procedure is another important thing.
okay.
Okay.
Yeah,
Uh,
operation, previous operation details and operation notes I didn't ask her.
Indication, yeah. Anybody wanted to comment upon her thing? Anybody?
Ma'am, well
Shall
done,
I
ma'am. She should have added this WHO surgical checklist, preoperative antibiotics.
Hmm.
And
WHO checklist, I think I told, ma'am, but
Yes, she told you. Yeah.
oh, sorry, I didn't notice.
It was a good presentation, and yes, almost everything was covered. Maybe we may add, maybe we'll see assess the need for drain after the second surgery if
yes,
it is required.
yes, yes,
Hmm.
And whether
yes,
she is a Jehovah's Witness also. That's all.
yes, yes,
Thank you.
yes.
And ma'am, one more thing. And there was really a nice presentation. In history, we have to evaluate the reason of bleeding, whether it was surgical or maybe medical comorbidities, like if she's on any anticoagulants
Yes,
or
so we are not seeing here only regarding the konje book. Okay, konje is giving me a task, but we have to evaluate completely, dear. So whether she is on any low molecular weight heparin. If there is bleeding, always ask about low molecular weight heparin. Similarly, if there is a paralytic ileus, always ask about patient is on codeine. Hmm?
Okay,
And if the patient is having oliguria, anuria, always ask about any nephrotoxic drugs. Hmm?
mm,
So these are at least points which you have to remember in your task. Always remember this. So
okay.
Konje, they are just giving us a scenario. We have to
Yeah,
evaluate the scenario according to our knowledge. Okay. Very nicely, Dr. Shaista. Very nicely. Okay. So let's go through the answer key. I have done it very elaborately. What would
okay.
be your initial response to this patient? So S bar is always must whenever you are facing a structured discussion. At least say one line or two line about the situation. Okay. So
Okay.
actually, this is a case of anuria in day two post-op. The TLH was done 12 hours, 24 hours back. Okay. And now patient is having anuria since 6 hours, and patient concerned about her vital signs also, and vital sign chart for 11 hours is given with you. It has been
Yeah.
uh, given to you. So
Yes.
this is actually exactly this will be looking like in the exam. Okay, you just need to see. This is not very bad chart. Okay, most of the times, most of the parameters are still under white in white line. Okay, not in yellow line. Most, see, BP is in white line, minute deviation in respiratory rate, and now minute deviation in temperature. Okay. So
Mhm.
sometimes the maximum things are in red. So that is alarming situation. Here, yes, here you can just go and talk to the patient. But whenever there will be maximum red things, do not talk to the patient. Start your CRMA approach. Start resuscitating that patient. It is resuscitation first, then you are going to ask the detailed history. Okay. So in this format, as you had asked a patient regarding the detailed history, I'm okay with that. Now, uh, so patient needs assessment and management. So I would like to move towards the patient and confirm patient's detail, introduce to her and nurse specialist. It is not the doctor in the ward. It is a nurse who has written it out. Okay. As of now, patient is hemodynamically stable, means the
Still.
pulse BP is still okay. She's having tachycardia, and systolic, diastolic blood pressure is little low. Okay, diastolic blood a
Mm.
little low. If you can read it out, so you can say that she's having tachypnea, she's having hypothermia and tachycardia, but her BP is on a lower side. Systolic and diastolic is on a lower side. BPs are on a lower side. Hypotension. Okay, so I will be asking her regarding the symptoms, specifically regarding the symptoms of breathlessness, pain in abdomen, whether she has been mobilized, started on orals, past flatters or bowel habits, any medication. I would like to know here is especially low molecular weight heparin, any medical comorbidities which will hamper her recovery, and any ability to any medical comorbidity which will increase her risk of bleeding also. So those are my questions here. I would be reviewing her first, followed by the her case details regarding her operation notes. Any difficulties, any bleeder, okay, who has done a surgery, what was the indication of surgery, and any risk
Mm.
factor, means any difficulty in securing hemostasis. So these all will be reviewed by going through her notes, confirm her examination, especially general examination, to see whether the patient is having parlor spelling I missed out. Okay. Pallor, abdominal swelling, tenderness, any vaginal bleeding. Okay. Check any catheter block. Anuria, again, the commonest means sometimes even the catheter is blocked. Ensure that the chaperone or the nurse specialist will be present beside my bed. Okay. Once this has been done, I would like to communicate with the patient about her condition and start her on resuscitative measures. Here, I will start her on fluids, IV fluids, okay, resuscitative fluids, keeping in differential diagnosis for anuria like dehydration, bleeding, and injury as a remote possibility. Insert two wide bore or single wide bore cannula also. Starter on IV fluids, crystalloid followed by colloids. Hydration is important. Take fresh baseline blood investigation, which will include, I have not elaborately mentioned here, but my main aim of fresh blood investigation is, just wait. Okay, fresh baseline blood investigations are full blood count, urea electrolyte, liver function test, kidney function test. Okay, here. So
Mm.
these are the investigation which you had also mentioned very nicely. Keep blood group, arrange blood and blood products for this patient. Inform consultant, inform theater, inform anesthetist also. Counsel the
Yes.
patient and inform ward staff, arrange ultrasonography. So here again one more means we will not suspect hemoperitoneum. We will always do see to it that we will at least confirm it by doing ultrasonography bedside. What do you think?
Mm. Yes.
Yeah, it has not been
Yes.
mentioned in the answer key, but
Yes.
apply your
Yes.
knowledge. Apply what we do. Will you be taking
Mm.
a patient directly without doing ultrasonography? No.
No.
Huh? If signs of hemoperitoneum, then arrange exploration with the consent. If other, okay, now here we are just giving a differential diagnosis. If other differential diagnosis comes up, we will act accordingly. Yes.
Yes.
What are the differential diagnoses? Yes, dehydration, hemoperitoneum. One more important point here is secondary port vessel bleed. Do you think that can be a
Yes, 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 ma'am.
possibility?
Mm.
Yes, so that is a possibility. Acute kidney injury because anuria. That is another possibility. Ureteric injury, infection leading to septic shock, which is less likely. I will not say. And catheter block is the most common, sometimes the commonest. And her signs could be because of excessive pain or even bladder distension give rise to you tachycardia and yeah. Okay, so catheter block
Mm.
also we add to see. What would be your management for this patient if hemoperitoneum? That is my specific question. If on any low molecular fatty parin, stop it immediately. Obtain a
Mm.
consent for exploration. Arrange exploratory laparotomy with consultant, anesthesis, theater team, and scrub nurse. Resuscitative fluids will be given. Plasma expanders will be given. Full trace all this investigation. Okay, assess a need for blood transfusion here. Hmm? Keep adequate blood and blood products handy. Consent, WHO safety checklist, exploratory laparotomy. Okay, approach will be midline vertical, infraumbilical. Uh, Identify any bleeders. Okay, identify any bleeders. Give and ligate. Okay, or secure that bleeder. Remove clots. This should have been first. Remove clots. Give wash. Uh, Drain is important because this is an exploration and closure as per the routine steps. This is my
Mm.
further management, followed by IV antibiotics, post-operative plan, post-operative care plan. Documentation needs to be completed. Patient needs to be monitored on NEOS chart, thromboprophylaxis, uh, discharge to community care with information to the GP and crystal clear advice regarding a follow-up and 24 by 7 contact details. These are important points. Debriefing, now here, dear clinical governance is not about so many points which you had mentioned. Documentation, tactics, informing risk management team regarding root cause analysis, debriefing, and offering her duty of candor. You missed out on duty of candor. It is very important. And if it is a
I
root cause
told,
analysis, duty of
I,
candor, I didn't listen. You mentioned
I,
about root cause. You mentioned about this, explaining her regarding the investigation report. Did you mention duty of candor? Duty of candor
uh,
means what it is. You mentioned
whatever
about
happened, the
root.
truth means like we
Yeah,
have
ma'am,
to tell her that.
she mentioned.
What you mentioned that sentence?
Um,
Okay.
patient should be explained about all the details, what has happened and what has been done uh,
No,
during the
this will
surgery.
not. No, no, no.
Um,
This will not be a duty on duty. Either
And
you
she
take
said,
a.
ma'am,
y-
she said everything will be transparently explained to the patient like that. She told.
Okay, being honest, open and honest is
No,
one
yes, ma'am.
sentence. Yeah,
I
being open
told.
and honest or duty of candor. This should be the very crystal clear. Okay. I heard about root cause analysis explanation, but not means the duty of candor. I didn't listen. Okay. Um, Now this has been completed. Your patient side clinical governance issues has been tackled. Now what about what steps you will be taking to minimize the situation in our clinical scenario? So institutional steps will be addressing any deficiencies, communicate to the operative team for self reflection, and we can have a case based discussion meeting in the department also. So these are the clinical governance issue regarding this cause.
Okay,
Okay. Now coming to
okay, ma'am.
the communication with patient and relative, here I will address, introduce, consent, communicate with the patient about the complication, debrief, and duty of candor. If you have done all these things, it's a clear pass for you. Communicate with the nursing staff. It was not a doctor. You thought of doctor, consultant, anesthetist, theater, blood bank, scrub nurse is one of the important point here. Okay, complete
Yes,
incident form and risk management team will be involved here. Okay, inform to GP for short term and long term follow up. Next is patient safety. confirm the details of the patient situation, that is CRMA accordingly. Resuscitation, here the resuscitation is fluid, consent, exploration, antibiotics, withhold LMWH. This is, I put it because if the patient is on a low molecular weight heparin, and you will not mention about low molecular weight heparin, it might be a star point. Thromboprophylaxis. If the patient is not at risk of bleeding, then thromboprophylaxis accordingly. Otherwise, mechanical thromboprophylaxis can also be started here. Hydration and mechanical thromboprophylaxis. Applied clinical knowledge, diagnosis, knowledge about postoperative complications, hemorrhage, differential diagnosis about deteriorating postoperative patient, know when to reoperate, and current literature of management of major complications in the surgery. So this is all a good task done by you, dear.